to start?
That's not, no, that's not mine. Yes. 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 Thank you. Thank you. Ready? Okay. This is an exciting day for global surgery. Welcome to our panel discussion on the role of students and schools in the future of global surgery. My name is Martha Vega, a recent medical school graduate and current Paul Farmer Global Surgery Research Associate at Harvard Medical School's Program in Global Surgery and Social Change. In this panel, we will try to answer the following question. How can universities, schools of medicine, and schools of public health engage and educate students across all disciplines on the challenges of global surgery? The recognition of the importance of surgery in public health is not new. In 1980, Dr. Halfdan Mahler, Director General of the World Health Organization, said, "Surgery clearly has an important role to play in primary health care and in the services supporting it. As it has been previously highlighted, the place of surgery within human health is not minimal. Surgery is required across all disease categories. According to Rose and colleagues, surgery plays a vital role among different categories of the global burden of disease, such as communicable disease, maternal health, neonatal disorders, non-communicable diseases, as well as injuries of various sorts." So, what is the role of surgical care in the health of populations? If you look at healthcare through the lens of the life course of a human being, or through the approach of disease burden, or by the level of care, you will see that surgery is present during all life stages and at all levels of care. There are significant needs surrounding global surgery education among institutions at all income levels. On an online comment at the Lancet Commission on Global Surgery website, a medical student from a low-middle income country states, "Being a medical student and young physician from an LMIC has not made it easy in global surgery." Among other comments, 2 common reasons were identified: limited access to information and absence of mentorship. In a survey at a high-income country medical school, of 102 respondents, 42% reported involvement in global health research, volunteer opportunities, as well as student initiatives. 68% desired an expansion of global health within their curriculum, yet only 12% felt like legitimate members of the global health community. At the same institution, after a global health conference, 77% expressed increased interest in global health activities, and many students newly considered surgery as a career choice. So 35 years later, after Mahler's statement on the essential role of surgery within primary healthcare, how can we ensure that this perspective is passed on to the next generation of trainees at institutions across all levels of income? In order to strengthen the field of global surgery, we must meet the needs of students by investing in global surgery professional training opportunities, by improving access to information in low-middle income countries, by incorporating global surgery and global health as part of the curriculum of our schools, and by creating gateways for collaboration and mentorship between US and international institutions. Personally, as a research associate for the program in global surgery and social change, my collaboration to this commission through a team effort, mapping population access to surgical care in various countries, and through my research on mobile surgery in collaboration with the Cinter Andes Foundation, founded by Dr. Edgar Rodas, such experiences have been extremely valuable and are pivotal in my career as a future global surgeon. To further discuss the topics on this panel, it is my honor to introduce to you Dr. Paul Farmer, Founding Director of Partners in Health, Chief of the Division of Global Health Equity at the Brigham and Women's Hospital, a prolific author, a strong global surgery supporter, and an advocate for healthcare of the poor. Dr. Julio Frenk, he is the Dean of Faculty at Harvard T.H. Chan School of Public Health, former Minister of Health in Mexico between 2000 and 2006, and he has extensive leadership experience working in important global health organizations. Dr. Robert Taylor, clinical professor at the Department of Surgery at the University of British Columbia in Vancouver, Canada. He has over 40 years of experience on war surgery and health system strengthening through surgical workforce and infrastructure development around the world. Dr. Mack Cheney, facial, plastic, and reconstructive surgeon and director of the Massachusetts Eye and Ear Infirmary, Office of Global Surgery and Health. Sarnai Erdene, a medical student from Mongolia's National University of Medical Sciences, who comes to share with us some of the barriers of surgical care in her country. And finally, Dr. Lars Hagander, consultant surgeon, director of global pediatrics at the Faculty of Medicine at Lund University of Sweden, and co-chair of the Lancet Commission on Global Surgery. Please give them a round of applause.
Thank you very much, Marta. That was a terrific summary. And unfortunately, it does oblige me to say, though, that I'm rather embarrassed still, all these years later, about the Paul Farmer Surgery Fellowship. When John Mira said he was doing this, we trained together 20-something years ago, I in infectious disease, he in ENT, and various other gazillion maxillofacial this, MBA that. By the way, where's John Tarpley? You know, training in infectious disease is helpful because I could have told you that if he had diarrhea, he should not have done a marathon. But anyway, when John said this, I turned an even pinker shade of my usual complexion and said, but I'm not dead yet. Now, but what made it worth it even then was knowing that we'd be training young people. Which is really, as Gary Gottlieb said, part of this, I think it was Gary who said this, post-flexionarian vision of what an academic medical center does. Links direct service delivery, care, to training, and to generating new knowledge. A noble mission also happens to be the one we took up at Partners in Health. Now, before we turn to a critical discussion of the role of students, and I really hope it will be critical. I'm going to pick up on what Craig said about not the neglected, the invisible friend of the, where's Craig? That was nice. Very good. Invisible little friend. I heard the word amiguito, which is how they say it, your little friend, like, of the neglected stepchild. You know, bringing students into this work is obviously the way to change the landscape, regardless of which field we feel is most neglected. And by the way, I have to underline the disturbing association between one's own professional training and the identification of the field that is most neglected. In other words, the anesthesiologist will talk about anesthesiology, the surgeons will talk about surgery. I'm not talking about this group, of course. But we do have to make a distinction between our own quest for personal efficacy, or QPE, and the quest for institutional efficacy, or QIE, which is the university promoting its own agenda, as opposed to the agenda of those who are left out of modern surgical care, which is not a couple of billion, but the majority of the world's population. And that leads to significant challenges in training students because there is, on the one hand, this is the only time in my life I'm ever going to get a chance to correct Dr. DeBoss. So I'm going to do it. Anesthesia can't be the dessert. It needs to be the appetizer. On the one hand, having been hit by a car, I can tell you the anesthesia needs to come first, before the surgery, dear professor and friend. On the one hand, we have the challenges of building a culture of safety, a culture of excellence, a culture of moving towards real equity, and quickly, if we're going to address these enormous gaps. And on the other, we have the risk of turning away. So if something isn't safe, then what's the next step? Is it saying it's not safe and moving on to someplace safer? Or is it taking, as these panelists have done, the step of sticking with problems and accompanying partners over the long haul? So I'm going to follow the format, ask each person a question, and then turn it over to everyone else. So we'll start with Julio Frenk, who's already been introduced. He may have to leave a little bit earlier. And there's a two-part question that I have. One is, when you're the Minister of Health, obviously you have to avoid neglecting one stepchild or any stepchildren. How does one move, and I'll blend these questions together, how do you move from being an academic to a policymaker, and the lead policymaker for an entire nation? And where do you see us moving in terms of having surgery considered surgical disease, becoming front and center in public health?
Thank you, Paul. Well, first of all, I want to congratulate John Miara and all the members of the Commission for this, the publication of this report. Let me just quickly address the first part and then say a little bit about what I think schools of public health bring to this conversation, because usually surgery and public health are not two phrases or two expressions that come together in the same sentence. It's almost like an oxymoron. But on the first question, I mean, what we do, whether we're in academia or in policy, is we are engaging with the most powerful element we have for enlightened social transformation, and that is knowledge. And we can be in academia creating or producing knowledge, and good policymakers use that knowledge translated into evidence to guide policy making. And I always like to speak of the circle of knowledge as what we do in universities. We create knowledge through research, we recreate it through education, because good education doesn't just transmit knowledge, it recreates it in the minds and skills of the next generation. And then we have a duty to translate knowledge so that then it can inform decision making at all levels by individuals who are empowered by knowledge, but also by policymakers. And I think if we look at us as part of, and then when knowledge is successfully translated, it leads to action, whether it's actual service, it changes reality and it forces then us to ask new questions. So universities have a key role in this, and I think when it comes to surgery and this potential oxymoron, I just wanted to bring here, because I'm probably the only non-surgeon here, and that was probably my main contribution to global health, was to stop seeing patients. I can no longer do much damage.
You only can say that when you're dean or the future president of a major university.
But, public health is defined by the fact that it takes an entire population approach. That's the defining feature of public health. And as such, it has two main components. You either look at the health conditions in populations, how they are distributed, diseases and risk factors and injuries. But an integral part of public health is studying the organized social response to those conditions, which is what health systems do. Health systems are the way in which societies articulate the organized social response to health conditions. And very often, when we talk about public health, we're thinking about the first set of issues, which is very important. This is what we do in epidemiology. And this provides a perspective that's different when you are residing in a health facility and analyzing the people who actually come through your door. You take an entire population, including all the people that never make it to the health system. But as integral a part of public health is studying the organized social response, the way we structure health systems. And there, the fundamental question is, how do you deal with priorities? I think the interesting part, I think the big step forward with this commission is that a lot of the global health discourse has been dominated by disease-specific, but in health systems, you act through platforms. Platforms like good information systems, or platforms like surgical systems and everything that go around that. And those platforms then are open, as was said in the opening commentary, are there available to tackle a multiplicity of diseases. And when you move to being a policymaker, this is the perspective you take. What are the platforms that address multiple conditions? What I would say, to finish, because I know the time is limited and we have many other speakers, is that in this process, universities in this circle of knowledge play obviously a very crucial role. That's the topic of this panel. And I think in particular, when it comes to global health, it is very important that this same framework that I use for public health is exactly applicable to global health. Global health is not foreign health. Global health is not whatever we're doing when we're not in our place of residence. Global health is about understanding the fundamental concept of interdependence, the fact that events that happen in one part of the world affect the rest. And it takes, in this population perspective, the entire population of the world in analyzing that interdependence. And I think this is a fundamental understanding. And therefore, in this notion of interdependence, we can look at health conditions, and there the fundamental concept is the international transfer of risk factors. Mm-hmm. And a lot of the underlying conditions that are amenable to surgical care have to do with the transfer of risk factors across borders. Obviously, the most clear example are infectious diseases, but lifestyles are also a big part of the international transfer, the exportation of cigarette smoking, unhealthy diets, environmental pollution, climate change, as a prime examples of that interdependence. And then we also look at the response, just like we do in national systems. There is a global health system. And a big part of that global health system is the workforce, as we have been talking. Because workforce is highly mobile, not just students and residents and fellows, but the workforce. I mean, a quarter of all physicians practicing in this country were educated somewhere else. And therefore, we need a global response to the challenge of educating the next generation of leaders, including in surgery. There was another Lancet report that I co-chaired in 2010 to mark the centennial of the Flexner report on the education of health professionals for the 21st century. And I believe some of the conclusions there really blend very nicely with this report when it comes to analyzing what do we do with students and what's the role of universities and schools of medicine and public health. And it basically advocates for competency-based education, starting with the end, rather than starting with the curriculum, which is the usual way we do things in universities. You start with the competences, the end product that you want, and then you work your way backwards to a curriculum. Second is the notion of inter- and transdisciplinary education. And that, I think, is critically important for surgery, especially in other settings. The surgery is not only what surgeons do. There's a number of very interesting innovations, and the report addresses that, of of technical surgical technicians, obviously the examples of Aravind Eye Care and other modalities of production, which, by the way, are now the subject matter of what's being called frugal innovation. A lot of those models or innovations are being imported in rich countries, just illustrating the interdependence. And in the competency set, I think a very important one is going to be cultural competency. And if one thing we've learned of Ebola is that we ignore local culture and engagement of communities at our risk. And I think that's equally applicable for all of these conditions. And the last point of that other report, which I think is relevant for today, is the idea that a global response has to include the development of consortia of educational institutions. Because it's not enough to send students and fellows and residents. It's the idea of helping to build or strengthen capacity locally so that we move from dependence, which is what very often happens in international transactions. We create dependence. If the people don't arrive there, the surgery doesn't happen, to true interdependence. And that will only happen if we develop a new model of global institution building in education through consortia where there's mutual accountability and mutual benefit of the institutions. And I think here at Harvard, we've been devoting a lot of time to how we do that in terms of creating global consortia. If anyone thinks that each of the sovereign nation states, whatever there are now 193 members of the United Nations, is by itself going to develop its full complement of capabilities by its own, that's not going to happen, and that's why we need this consortium. I think technology is going to be a big driver of this in education and also through telemedicine and other innovations, but in the end, it's the commitment to understanding interdependence and realizing that it is not just out of solidarity, but out of the idea of building a true global society that we need to find these new forms of engagement of universities with their counterparts around the world.
Thank you, Julio. And I'm going to just move over to Robert by taking that idea of exporting risk and importing risk. And Robert, you move between an affluent and peaceful, or at least that's our impression here. Your neighbors to the north think, Canada, they're all so nice and pleasant. We'll go back to Mexico in a second. And some very difficult circumstances and settings. Can you just tell us a little bit about, because I'm obviously just saying export of risk, I'm talking about weapons. There's a transnational, transregional trade. I mean, Sierra Leone, we seem to have forgotten, was at war for an awfully long time. That was a regional war, and if you look at the absence of the staff, space, and systems you need to provide good surgical care, it's obviously related to that. How do you engage students in your work between point A and point B, where point A is Canada?
Well, that's a very good question, and a heartfelt one. Sometimes working internationally, you become very aware of the gaps, the discrepancies, the injustices. But when you work in a low-income country or even in a low-resource setting within that country, which is also affected by a disaster, and perhaps also thirdly affected by an armed conflict. And you put those all together, you realize just how much the people with whom you are working have lost. Not only have they started out from a low point, but they've lost a lot of things that we don't even think about. They've lost social capital. They've lost health-seeking resort. I'm sounding like Julio now from talking about public health, but the health-seeking resort that we heard this morning, all those things are gone. All those supports, all the things which give social resilience are gone. And so how do you communicate that to students with whom you are working? I still struggle with that. I think you communicate that through obviously mentorship, through teaching, through spending time with people. You can also try to communicate that through courses, and we've certainly tried to do that in the courses that we've been building at UBC in global surgery. Perhaps something that Robert Riviello said this morning, which I really appreciated, that and the humility aspect of it, going fishing with somebody, those things all come into it. I don't have all the answers to that. I know that just spending time with people to communicate that, certainly mentorship, the mentorship role of people who have worked internationally with those young people who are keen and want to be involved is crucial. It's very important.
Thank you very much. And to make a plug for cultural humility, and not a plug against cultural competence,
No.
but it is an illusory goal. Usually, most anthropologists would say that cultural competence requires decades and decades of work and cultural humility. Lars, you're building a course. How will you, in a program between Harvard and Lund and other institutions that don't have the great good fortune of Sweden, how does it feel to be the bellwether of good stuff as opposed to bellwether of badness? How are you incorporating these ideas in your of cultural humility, of accompaniment, into training programs?
Thank you very much. I mean, we surveyed all medical graduates in Sweden last year. And all
socialism allows that kind of stuff.
Yeah, we do. It sure does. And believe it or not, but when Swedish medical students, and I after 2 years in Boston, I hear this all the time. Soon I believe in the fine picture you have of Sweden. But when medical students graduate from medical school in Sweden, more than half of them, they don't know about health systems. More than half of them, they don't feel that they have knowledge and skills when it comes to health equity issues, about global health, about social determinants of health, etc. So they can go the whole medical school and they have had no teaching on those issues. And the funny thing is that if they had training in global health or cultural awareness, and there was this strong correlation between the medical students who felt that they had these these skills that are very useful for a very domestic Swedish doctor. And the students, they realize this. Almost all of the students want to have global health teaching as part of their medical curriculum. So what we, in my university, partly because of this information, they are changing the clinical part of the latter half of our medical curriculum. So we're going to start off halfway with a foundation course in global health, compulsory for all medical students, and then in each clinical subject there will be a little flavor of global health, in that subject, there will be in different ways. And at the end of the medical training there will be electives where you can focus, if you want to, in global health. And what we are offering in that part is a 5-week elective course in global surgery. So 2 weeks with lectures at home, interacting with international collaborators and international students, and then 2 weeks of travel to, in this case, Harare, to really get a feel and work with the medical students of a different university, and then another week of exams, etc. And the pitch that we are making to our faculty is that these students, they will learn surgery through the context of global health, but they will also learn global health through the lens of surgery. And we have been able to make that case.
Thank you. And Mack, you look around this room and at the Commission, and we all know that the Commission and its products occurred because of the youthful engagement and vigor of those who were recruited by John and Lars and Andy into this work. And so that's a backwards compliment, by the way, Sarah. Cool. And Jim. Anyway, you got that, right? You're quick like that on the uptake. So you work in a highly technical subspecialist field. Clearly, the students do not have competence in that kind of work. That's why they haven't done their training yet. You could argue that cultural humility is a consummation devoutly to be wished. You could talk about culture of safety, et cetera, et cetera. How do you see students and trainees incorporated earlier in the kind of work you do?
Yeah, well, thanks, Paul. It's an honor to be here on this panel. I almost didn't feel like I should be amongst this group, but I'm glad that I am. And when I was getting ready to kind of getting my thoughts together, I thought maybe the best way to add something to this discussion is to talk briefly about the 20 plus years of mistakes that I've made, because I've made a lot. You know,
Well, John Tarpley is the world record holder.
No, I don't think. I think I've got a few more, but my background and a lot of my comments are driven by 20 plus years of doing what I would call traditional mission work. And I've often heard you say, Paul, you know, where are all the surgeons? And I would venture to say that most of the surgeons were not inactive in global surgery activity. They were just involved in a model that has really been proven to be not that effective if your goal is capacity building and accompaniment, which is where my thoughts have come over the last 2 decades. So I think I've spent a lot of time thinking about accompaniment, what that means. You know, I know you had, you know, it's an incredibly powerful philosophy, I think, moving forward in surgery. And it's something that we've tried in a very primitive way to start, and our particular focus is in Uganda right now. And we've started by looking at the site very carefully, making sure it's a good match for us, with the goal that we're going to produce academics within this environment that'll stay there and then generate the next generation of surgeons. For us, it's head and neck surgeons. But it's a model that hopefully could be used by any surgical specialty. Actually, I have some slides that have...
Well, you know, let me suggest, Mack, if I can, that we see if we have time to go back, because we do want to open it up.
Okay.
And just hearing you reflect on the things that weren't done right and correcting is very fortunate. And I have to say, Mack, I never thought I'd hear a bunch of high-level surgery professors talking about accompaniment, and rather delighted.
Well, it's a very powerful message, and I think it's something the group has to really embrace in order to make progress in surgery, not just in a superficial way, but really deeply feel that way. I think it embodies humility, it embodies collaboration, and embodies a lot of the things that will be essential in making an impact in the parts of the world that everybody else has talked about need our help.
Thank you. And if I could go on now to our last panelist, Sarnai. So Sarnai, you're, if I'm not mistaken, being a great diagnostician who can tell people with diarrhea not to run marathons, that you are the youngest person on the panel. And you're been at the National University of Mongolia.
Yes.
And you've heard a lot of discussion today and in the course of the past year about outmoded models and incoming models of engagement. And again, we haven't really talked about engaging the team, the nurses. A couple of people did mention nurse anesthetists. And not to put the whole thing on you, but how would you like to see things changing in terms of student engagement?
Okay. First of all, I would like to all know that we don't speak English in Mongolia, and it's my first time ever in English-speaking country. So if
we all speak Mongolian here.
So if I make any mistakes, please accept my apologies in advance. So, and I also would like to thank you all for this great opportunity to be here with these all wonderful people. So here, I want to talk about my medical school system, which is far different from what you have here or what you have in high-income countries. Our university have block system where the 6 years of bachelor study is divided into 21 blocks, and each one block are concentrating on one subject, cardiology or neurology. And first aid is taught on second year as a part of one block, and surgery and trauma are taught together in one block, which is only for 2 months. So that's not enough for the students to get to know about the surgery and emergency care. On the other hand, after graduating from the university, we are ordered to work in rural areas where people live 5 or 10 kilometers from each other, sometimes more than 20 or 50 kilometers from each other and from the hospital. So, in my opinion, getting good knowledge and practicing more first aid, basic life support, and ATLS is very important, not only in low or middle-income countries, also in high-income countries' students. Next thing is language barrier. As I told you before, we speak only Mongolian, and not many people speak English.
All evidence to the contrary.
So one of the main goals of the students must be to be able to communicate with the international colleagues and exchange experiences.
Yeah. Well, first of all, thank you, and you're wrong about the English. I'm right about the Mongolian. I have just crossed the blood-brain barrier and asked John Mira if we could have a few more minutes, and he said yes. So let's just, what I could say is maybe we could have 2 pressing questions and just ask for, a super concise, which is concision not our strong suit, clearly, response. Or one really perfect student-related question, an SRQ.
Thanks, everybody on the panel. I'm John Welch, nurse anesthetist at Boston Children's Hospital, as well at Partners in Health, and most recently was on the clinical leadership team with our Ebola response with Partners in Health. I'll have to apologize to Dr. Farmer for a little bit of QPE here, but I hear
You're forgiven, you have skills.
I hear terms like transdisciplinary, interdependence, workforce, et cetera. I just wondered if anybody on the panel might address the synergy and collaboration required between colleges of medicine and public health and their counterparts at colleges of nursing to create an integrated approach to global anesthesia and surgery. Note I used anesthesia first.
Terrific. Do you, please go ahead and introduce yourself as well.
Hi.
Thank you, John.
My name is Andrew Kim. I'm a first year at Harvard Medical School. I guess my question is, we're going into training in a very particular model of a surgical training pipeline and an organization of surgical subspecialties in the United States. And I guess my big fear amongst many fears is that I'll become very myopic in terms of the best way to do things. And I was curious to hear about how we might fight or prevent that narrow-mindedness of assuming that the way that we are trained in is the way to train, and allowing for a fair assessment of various types of surgical training and delivery models.
That's a great question. And just to make them one, did anyone ever tell you that you look like an orthopedic surgeon, by the way? Just to make them one question about humility and, that was a compliment, don't worry. About humility and also, or avoiding myopia, which I would regard as a question about humility, and how we think about training as beyond just students of medicine or trainees, but rather the teams that we work with. Yeah, Robert, you start.
Yeah, that's great. And about a decade ago, when we formed this a unit within the Faculty of Medicine that we called the Branch for International Surgical Care. And we had a big discussion on why we were calling it surgical care instead of surgery, because we felt surgical care was the whole field. And you've heard all about that this morning, and that's true. And then when we began holding formal academic grand rounds in that, our invitation went out right across the board. So we had people from all surgical care disciplines, not only across the Faculty of Medicine, we had people from biomedical engineering coming, we had people from nursing coming, and that has been a real impetus in the way that we have proceeded. And the courses that we have developed, we've put together a number of courses now, and we have an online graduate certificate in global care. And of those, there have been nurses and biomedical engineering take those. So what we're trying to do is put a body of knowledge around one's personal, professional development in order to allow a person to work globally more credibly and more prepared.
Terrific. Julio, I'm going to, knowing your deep interest in epistemology, which probably others might not know, go back to Dr. Kim's question. How can that kind of transdisciplinary, trans-professional, trans-local approach that Robert just described help us avoid that kind of myopia?
Well, to put the two questions together, I mean, one of the big proposals is exactly for interprofessional education. There's a whole movement, there's a collaborative around this, and the fact is that the health systems have become so complex that they require teamwork, and yet we don't educate our students in that. And learning to work in a team is in itself a competence that needs to be developed during the educational experience, but we educate students in silos: medicine, nursing, pharmacy, biomedical engineering, public health. Then we expect that somehow they will find their way in the workplace and learn how to work together. It doesn't work like that. So that's what that movement is all about. We add in this other Lancet Commission on Education of Health Professionals for the 21st Century the notion of trans-professional, because we believe that you need to create a common educational experience, certainly for the health professions, medicine, nursing, and other health professionals. That's the post-secondary education. But you also need to bring technical and community health workers, which in surgery are absolutely critical, especially in, as I was saying before, in a lot of low resource settings. And I think it's going to also happen in high resource settings like the US, as they are looking for more efficient modes of delivery. And I think your experience with Partners in Health, with the accompagnateurs, also here in Boston, is a great example of that. So it's also trans-professional. The rest, the non-professional part of the team, has also to train together and have common educational experiences. And what you have there is not the specific technical competencies, it's the cross-cutting. The model I use is that we've been training I-shaped individuals, and we need to train T-shaped individuals. We need to develop cross-cutting competencies that, among other things, allows you to be a critical problem solver. Doesn't matter what is your field, what is the vertical part of the eye. It's those cross-cutting competencies. It's communication, it's a lot of the cultural humility, and it is the capacity to work as teams. So public health schools have a big part here, because most of the interprofessional education movement has been among the clinical professions, mostly medicine, nursing, and other professionals. Public health, because it's not based on individuals, but it takes the population perspective, I think is fundamental, because I do believe that every clinical health professional needs to understand the population from which the patients come from. And this is the whole population health movement that now has become very popular here. And that's what we bring to that conversation. And that includes understanding the population and then understanding the health system, those platforms. How do you organize it? How do you measure that? We doctors tend to be very focused on the service delivery. In public health, we're more interested about the impact. We look at topics like quality of care, not just access, but what actually happens with the care that is provided. I think those are all fundamental topics in the interprofessional and transprofessional conversation, which doesn't stem just from the care of individuals, that's very important, but provides this larger contextual element, so that our graduates are not just great professionals and great experts, they're also change agents who understand the context. So my answer to the student is make public health part of your education, and that will cure your myopia.
There you go. Lars?
Yes, I also would like to address, was it Michael? Andrew, sorry. I just half an hour ago, I got an email from the Global Surgery Group of the International Federation of Medical Students Associations, which they collect more than 100 countries. And they say this: as surgeons of 2030, we wish to raise some key concerns and highlight suggestions to help work towards reducing global surgical inequality. Firstly, and I encourage them to publish this, firstly, despite the admirable work undertaken by the newly emerged field of global surgery, the concept is somewhat foreign in many places. Emphasis must be placed on local surgery, surgical inequity being part of a local issue of global health importance. Secondly, exchanges in workforce and training between countries must be held bilaterally, they say, as students traveling back and forth. And our third point addresses the greater need for exploration of technology. They are used to Skyping and being in contact, and they can see that value being in teaching. Finally, we would like to remind the Commission that investment in future medical staff and workforce is impossible without investment in medical students from all around the world. Mentors and guidance, as well as research and practical opportunities, are all paramount to training Generation 2030 of surgeons, anesthetists, nurses, and obstetricians. So that's the echo of your concern there from this group. Thank you.
Mack, Sarnai, closing thought? Go ahead.
Okay. Thank you again for you all for this great opportunity, and we all appreciate it. Thank you very much.
Yeah, nothing really, Paul. I think what I would love to see moving forward is a reaction to the Commission report, which is packed with incredibly valuable data, to a step where we have some model that really can create a new generation of surgeons, indigenous surgeons in these countries that need it. And I hadn't heard a lot of talk about that, but how do you actually take what happens at Harvard Med School or in Sweden, where you can train surgeons, they're coming out, you can train anesthesia people, they're coming out every year, they're well trained, they have an academic background. How do you create that in Uganda? How do you create that in Haiti? How do you take the data that's been produced by the Commission and translate it into increasing capacity?
All right. Thank you for that challenge, Mack. The challenge is, how do we go from a nice report on paper to seeing the implementation and the building of local capacity? So I think that was a well-placed comment on the word global. Well, thank you all, and thank you, John, for giving us an extra few minutes.